Welcome back to USMLE with Varun. This is the final completion module for our psychiatry system for USMLE and NEET PG. In this video, we'll cover a set of extremely high yield concepts that are commonly tested but often scattered across textbooks and question banks. Think of this as the final polish to make your psychiatry preparation exam ready. Before beginning with the video, I would like to request all of you to please subscribe and keep supporting. This lecture series is provided free. There are no paywalls. If you find it useful and wish to support its continued development, voluntary contributions are welcome. All content will remain free to access. Uh, the link is on the screen and I'll also pin it in the description and pinned comment. You can pay with any of these payment methods. If you want high yield notes of psychiatry, you can just mail me at usmlewithvarun@gmail.com and notes will be sent in 48 hours post payment of a nominal fee. So far, we covered the core psychiatry systems in parts 1 to 4, but psychiatry also includes many short high yield concepts that don't fit neatly into one system. Think like conditioning, defense mechanisms, dissociation, child psychiatry, substance use patterns, ECT, and many more. This video brings all of those together in one structured place so your preparation becomes complete and coherent. So topics covered in this video includes we'll touch on learning theory, psychodynamic concepts, development, child psychiatry, dissociation, pregnancy psychiatry, ECT, secondary gain disorders, somatic and eating disorders, sexual and elimination disorders, gambling disorder, behavior change models, substance intoxication and withdrawal, and Wernicke-Korsakoff syndrome. All of these are in a high yield pattern based format in this video, so please watch till the end. Uh, let's start with learning theory. So, classical conditioning is learning by association between two stimuli. A neural stimulus becomes linked to a natural stimulus and starts producing the same response. The classic medical example is a chemotherapy patient who feels nauseated just by seeing the hospital corridor, even before receiving treatment. No behavior is required. The patient is passive. That's classical conditioning. So the key components of classical conditioning includes neutral stimulus, unconditioned response, conditioned stimulus, and conditioned response. Operant conditioning is kind of different. Here, learning happens through consequences of behavior. If a behavior is rewarded, it increases. If it's punished, it decreases. For example, a child studies more after receiving praise. That's a positive reinforcement. This is active learning. The patient or person does something positive. Transference. Now let's move on to psychodynamic concepts. Transference happens when a patient unconsciously transfers emotions from important people in their past onto the doctor. So, a patient may start seeing the doctor as a father, as a figure, as a mother figure or a father figure, or someone they previously feared or depended upon. So it's not logical. It's emotional and is unconscious. So this transference is not logical. It is very common in therapy questions. So whether to look out if there is any transference seen. Countertransference is the reverse. It's when the doctor develops emotional reaction towards the patient. For example, feeling unusually protective, feeling irritated or emotionally attached. This matters because it can interfere with objective clinical judgment. So when we try to differentiate between transference and countertransference, a simple rule is that transference is something from the patient to the doctor, whereas countertransference is something that goes on from a doctor to a patient. So if you remember that direction, you will never miss these questions. Now let's study about ego defense mechanisms. Defense mechanisms are unconscious tools that the mind uses to reduce anxiety. So everyone of us uses them some part of the day, some day of the year or so. The exam tests whether you can recognize them in clinical scenarios or not. Okay. Yeah, so now let's discuss about common defense mechanisms. So denial is refusing reality. Projection is blaming others for their own thoughts, like attributing feelings to others. Displacement is shifting anger to a safer target, like they shift their emotion to a safer target. Repression is forgetting trauma. Regression is behaving childishly. Rationalization is making excuses. Sublimation is channeling impulses productively. Yeah. If you get frustrated, you can just sit down and start studying. So when you channel impulses towards productivity, so it's an example of sublimation. Reaction formation is acting opposite to what's needed to be done. Intellectualization is using logic to avoid feelings. These appear everywhere in psychiatric questions. Denial, projection, displacement, repression, regression, rationalization, sublimation, reaction formation, and intellectualization. So grief is normal response to loss. We all cry, we all sleep poorly sometimes, we all lose appetite, but we gradually improve when we come across a disheartening situation. So people cry, they sleep improperly, and they lose their appetite. But at the end of the day, it really improves with time. So if the symptoms are severe and persistent, and they cause functional impairment or they cause a person to get disabled for months, it becomes complicated grief or pathological grief. Uh, Types of grief includes normal grief generally improves. Major depression does not. The key difference is in grief, self-esteem is preserved, whereas in depression, self-esteem is lost. So that single detail solves many exam questions. I want all of you to remember that. Coming to infant development milestones. So one thing is that I want to let you know that USMLE loves milestones. So it actively tests on milestones of infants and children. So we need to remember key milestones. So social smile by 2 months, sit by 6 months, uh, stranger anxiety by 9 months, first words and standing by 12 months, walking by 18 months, and two-word sentences by 2 years are the key milestones that needs to be remembered. 2 months, social smile, 6 months, sitting with support, 9 months, stranger anxiety, 12 months, uh, first few words, and also the kid starts standing up at 12 months, uh, exactly at the birthday. So 18 months. uh, the kid starts walking well. Uh, by 2 years, they start speaking two-word sentences. All right. So now let's discuss about child development. Uh, Toddlers do parallel play, whereas preschoolers cooperate. School-age children form peer groups, and adolescents search for identity. These four things we have to remember. So when we try to understand about the developmental delay patterns, so if there's no stranger anxiety by 9 months, so that is something abnormal. If the kid doesn't start walking by 18 months, the normal milestone is around 12 months. If the kid doesn't even start walking by 18 months, so that's called as a delayed milestone. If there's no speech by 2 years, that's an abnormal condition. So always compare age with milestone. Child abuse may be physical, sexual, emotional, or neglect. Always think of abuse when injuries don't match the story or the history. Whenever some parents or guardians give you a history, and you try to match it with the uh, uh, injuries that are seen on the child. We have to always think about child abuse. So these can be of four types: physical abuse, sexual abuse, emotional abuse, and neglect. High risk groups includes infants, children with disabilities, and children coming from a low socioeconomic status. The red flags in child abuse includes bruises in different stages of healing, injuries in hidden areas like back and thighs. If there's a fearful behavior in child, if the child is always fearful and always scared of every single small thing he comes across, so we need to suspect child abuse because that may be because of his trauma. Uh, if there's a delay in seeking medical care, and if there's inconsistent history, and if most importantly, if the injuries don't match the history or the story told by the parent or the guardian, you have to think about child abuse. Management is medical stabilization, and most important thing is that we have to report uh, any case of child abuse to authorities. When we try to study about ADHD, we need to understand common disorders includes sorry. When we try to understand childhood disorders, we need to understand that common disorders includes ADHD, autism, conduct disorder. We have tic disorders and elimination disorders. So first of all, we'll try to study about childhood disorders, and the first thing is ADHD. So ADHD uh, is said to be diagnosed in a child when there's inattention, hyperactivity, and impulsivity in more than one setting. So treatments includes stimulants like methylphenidate and atomoxetin, which is a non-stimulant. So stimulants and non-stimulants. So example of stimulant that is given is methylphenidate, and example of non-stimulant that is given is atomoxetin for ADHD. Uh, when we try to discuss about autism, we have to understand that autism presents with features like poor eye contact, there's delayed language, there is repetitive behavior, and there is restricted interests. So the USMLE clue in identifying any case of autism spectrum disorder, you need to look for a pattern in the question that if there's a mention of no eye contact, if there's a mention of if there's a mention of language delay, and if there's mention of repetitive actions and repetitive behaviors, and if the kid tries to restrict his or her interest, then you have to think about autism spectrum disorder. Conduct disorder features includes aggression, theft, and rule breaking. So, aggression towards people or animals, destruction of property, lying or stealing, and serious rule violations. Conduct disorder in childhood is something that poses a very high risk of antisocial personality disorder in adulthood. So both in both the disorders, the features are same, but in children, if the age is less than 15 years, so they are marked as patients with conduct disorder, and if they're older than 18 years, they're marked as patients with antisocial personality disorder. Uh, Tic disorders are sudden, repetitive movements, or so tics are nothing but sudden, repetitive movements or sounds. So the types of tics includes motor tics and vocal tics. Tourette syndrome is both motor and vocal tics for more than 1 year. Elimination disorders uh, includes enuresis after age 5. If there's urinary incontinence after age 5, so that can be an elimination disorder. If there's fecal incontinence after age 4, that can be encopresis. So this is also an elimination disorder. The causes includes stress, which is the most important cause of elimination disorders. After stress, other causes includes constipation and developmental delay. So when we try to study about amnesia, we need to understand that amnesia is nothing but loss of memory. So this amnesia can be either a neurological amnesia or psychological amnesia. Okay. So types of amnesia includes retrograde, where the patient cannot recall what happened in the past, whereas anterograde amnesia is something that is characterized by a patient not able to form or create new memories in their mind. So this is seen in head injury, alcohol use, and dissociative disorders. Dissociative amnesia is sudden loss of personal identity after trauma. Uh, but there's a normal neurological examination, which is the most important thing to remember. So the USMLE clue in any question involving patterns of dissociative amnesia is that the patient forgets identity after traumatic event. So we need to remember this pattern. Uh, so coming to dissociative identity disorder, the features includes two or more identities with memory gaps. So there are two or more distinct identities with gaps in memory. So there's a history of severe childhood trauma, which is the most common possibility seen in every kid who has a dissociative identity disorder. So whenever a question mentions that the patient reports losing time or being told they behave like another person, just like we have watched in few movies where characters show dissociative identity disorder, uh, like uh, like a woman who feels like a devil or some kind of attributes himself or herself to uh, uh, another character. So that can be an example of dissociative identity disorder. Depersonalization and derealization. Depersonalization is feeling detached from own body or thoughts. Okay. Whereas derealization is feeling detached from surroundings. Depersonalization is feeling detached from self, whereas derealization is feeling detached from the surroundings. Self, personalization, depersonalization, and surroundings, derealization. The key point is reality testing is intact. Patient knows it is abnormal. It is ego dystonic. So we have to remember that this depersonalization and derealization is a dystonic condition. Ego dystonic condition. Okay. So now when we try to understand about psychiatric disorders in pregnancy, uh, depression and anxiety are common. Postpartum psychosis is an emergency. It needs to be treated as an emergency condition. The drug principles in psychiatric disorders and pregnancy is that we have to avoid valproate and carbamazepine. As we have already discussed, valproate causes neural tube defects in the fetus. So valproate should be strictly avoided. And carbamazepine should also be avoided. Both of these are teratogenic to the fetus. Lithium increases the risk of Epstein's anomaly. Uh, SSRIs are often used cautiously in patients who have been suffering with psychiatric disorders during pregnancy period. So, but ECT is safe during pregnancy. That's what we have to remember. So, we have to balance maternal benefit versus fetal risk while assessing and while prescribing treatments. Electroconvulsive therapy is used for severe depression, is used for catatonia, is used for psychotic depression, suicidality, and when drugs fail during these conditions, like severe depression with suicidality, psychotic depression, catatonia, treatment-resistant depression, and when drugs fail, we need to use electroconvulsive therapy. So the mechanism is that they induce a controlled seizure under anesthesia. So a controlled seizure when induced under anesthesia, it's called as electroconvulsive therapy. ECT side effects includes temporary memory loss and confusion and also headache, but we need to understand that it saves lives. So this is the most important thing to remember. Even though it causes temporary memory loss and confusion, it saves lives. So ECT is such a crucial aspect of psychiatric therapies, and there's a lot of research happening around electroconvulsive therapy and cognitive behavioral therapy because everyone believes that with more and more advances in research, ECT and CBT could solely help dealing with a lot of psychiatric conditions. Malingering is intentional symptoms for money, drugs, and legal benefit. This is not a psychiatric disorder. There's intentional production of symptoms for external gain. So examples of external gain includes money, avoiding work or exams, avoiding legal responsibility, and getting drugs. So the key point is that it's not a psychiatric disorder where, for example, let us think an employee just fakes getting a fever or fakes getting a headache or fakes getting a lot of abdominal pain just to get a leave, just to get a sick leave, just to get a paid sick leave, something like that. So that's called as malingering. Whereas factitious disorder is intentional production of symptoms without any external reward. So they just want to assume the sick role. They just want sympathy from people. They just want someone to just look after them. So that's what they care about and that's what they strive for. So the classic example of this factitious disorder is Munchausen syndrome. So when we try to compare malingering and factitious disorders, malingering is for external gain, whereas factitious disorder is for attention. So these people are attention seeking. They want sympathy. They want someone to look after them. So malingering is intentional. There's external gain present. This is not a psychiatric illness, whereas factitious disorder is intentional. There is no external gain. No, all they want is attention, and this is a psychiatric condition. Now, when we try to discuss about somatic symptom disorders, we need to understand that there are physical symptoms with excessive worry. Okay, there are physical symptoms along with excessive worry. Excessive worry for greater than 6 months, as we have discussed, is seen in generalized anxiety disorder, whereas excessive worry along with physical symptoms, we need to think about somatic symptom disorders or somatic disorders. There's no sufficient medical explanation related to these somatic symptom disorders. Types of somatic symptom disorders includes yeah, like illness anxiety disorder and conversion disorder. Conversion disorders includes when there are neurological symptoms with no organic cause and they are triggered by stress. So features includes neurological symptoms like paralysis, blindness, and seizures, which are inconsistent with anatomy. These are triggered by stress. These are triggered by extreme emotions. So whenever a patient comes across an extremely stressful situation and undergoes under a lot of emotions, what happens is that they show neurological symptoms like paralysis, blindness, and seizures. Whenever we try to analyze uh, these patients, there are normal investigations, but there's a dramatic neurological deficit despite normal investigations. So this is something called as a conversion disorder. Now let's discuss about eating disorders. Main types of eating disorders includes anorexia nervosa, bulimia nervosa, and binge eating disorder. So whenever you come across questions involving words like weight, eating behavior, and compensatory actions, you need to think about these eating disorders. Anorexia nervosa features includes low weight gain, very low body weight. There's intense fear of gaining weight despite eating very, very less. There's amenorrhea, which is a most common feature that is seen in patients with anorexia nervosa. In women who suffer with this condition, there's amenorrhea and there's distorted body image. Also, the most important complication is bradycardia. All right, bradycardia. So the features includes very low body weight, intense fear of gaining weight, distorted body image, and amenorrhea, which is the most common feature. Complications includes bradycardia, hypotension, electrolyte imbalance, and osteoporosis. All of them because of malnutrition. Bulimia nervosa features includes there's normal weight or near normal weight, but there are there is presence of compensatory behaviors like vomiting, and there's a there's a chance that they might be using laxatives. So they have recurrent binge eating. So what they do is they just eat a lot of food. They just binge eat food, and they try to get rid of the calories by using compensatory behaviors, like they just try to vomit food after satisfying their stomach. They just try to vomit out the food, and also they also tend to use a lot of laxatives. So this can cause. So when someone vomits gastric juice, it might cause dental erosion. So we need to look for dental erosion. We need to look for parotid swelling and also calluses on the knuckles of the hands. So whenever you come across a question mentioning dental erosion, parotid swelling, and calluses of knuckles, you need to think about compensatory behaviors in a patient with bulimia nervosa. So now let's discuss about sexual disorders. The categories includes sexual dysfunction, paraphilias, and gender dysphoria. Sexual dysfunction, there's desire, arousal, and orgasm disorders, whereas paraphilic disorders includes recurrent abnormal sexual urges. And there's gender dysphoria. So these three are the categories of sexual disorders. Drug associations includes selective serotonergic reuptake inhibitors, they decrease libido. We have already discussed this twice or thrice in the previous videos. The most important side effect of SSRIs is sexual dysfunction and decreased libido. We need to remember this at any cost. This is a highly tested point on USMLE. So when we try to discuss about now let's try to discuss about gambling disorder. So gambling disorder is a type of behavioral addiction. There is loss of control, and the patient always chases losses. So there's persistent gambling despite continuous losses chasing him. He always continues to chase losses again and again. So this can lead to financial problems. This is a behavioral addiction. There is no substance involved here, but it's an addiction without any substance involved. So gambling disorder is also some kind of substance disorders like kind of disorder without any kind of substance. This might be confusing, but you have to understand it. So now let's discuss about trans-theoretical model. So there are different stages. There are different stages in a behavioral change. So before some behavioral change happens, there are different kinds of stages. So this trans-theoretical model of change, which is used to bring up a behavioral modification in any kind of patient through psychological counseling. So there are 5 steps in this. So the first thing is the pre-contemplation stage, where the patient is not ready to accept whatever the therapy or counseling might be. Contemplation stage, where the patient starts thinking about change. Preparation phase, where there's planning happening. Action, where there is changing behavior. And maintenance, where the counselor, the psychologist, tries to prevent relapse in the patient. So there are 5 stages in this trans-theoretical model of change, of behavioral change. So these includes pre-contemplation, contemplation, preparation, action, and maintenance. So this behavioral change model is used for in cases of in treating cases like smoking addictions, where to 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 just help with smoking cessation, people suffering with alcohol use disorders, and someone who wishes to change their lifestyle. So these 5 stages are used in bringing up a behavioral modification: pre-contemplation, contemplation, preparation, action, and maintenance. Now let's discuss about substance framework. So always think about intoxication versus withdrawal. So whenever you come across a question mentioning substance use, you have to identify whether it's mentioning intoxication features or withdrawal features. So both of them carry life-threatening complications. Not just intoxication, but withdrawal also carries life-threatening complications. So this is both clinically and exam-based, both ways. So, an ability to identify intoxication and differentiate between intoxication and withdrawal features is a key concept. So, withdrawal from depressants can be fatal. Withdrawals from stimulants is uncomfortable but not fatal. But withdrawal from depressants, remember this: withdrawal from depressants can be fatal. Depressants intoxication. So whenever there is depressant intoxication, there is slurred speech, there is ataxia, and there is sedation. So for every drug, we need to identify intoxication features, withdrawal features, and life-threatening complications. Withdrawal from depressants can be fatal. Withdrawal from stimulants is uncomfortable but not fatal. Now, let's try to discuss about depressant withdrawal. Like the features of this includes tremors, anxiety, sweating, tachycardia, seizures, and delirium tremens. So, this depressant withdrawal is life-threatening. This is fatal. So, it's a medical emergency. Whenever patient shows features of depressant withdrawal, it should be identified that it's a fatal condition and it should be treated as a medical emergency at any cost because it is severely life-threatening. So, treatment of this depressant withdrawal uh, includes giving benzodiazepines, and we should also give thiamine along with glucose in alcohol withdrawal patients. So, uh, always give thiamine before glucose in a patient uh, who have been suffering with alcohol withdrawal because this rule where we give thiamine first and then glucose, this helps prevent Wernicke's encephalopathy. So, when we discuss about stimulant intoxication, we need to understand that whenever there's intoxication with stimulants, there are features like agitation. There is chest pain, there are dilated pupils and there is paranoia. There's euphoria, increased energy, decreased appetite, dilated pupils, tachycardia, hypertension, and paranoia. Examples of stimulant intoxication includes intoxication with cocaine, amphetamines, and methamphetamine. So whenever you come across chest pain, agitation, and dilated pupils in a question, you need to start thinking if there's presence of any features of intoxication, and you have to identify if there's any history of drug abuse like cocaine, amphetamines, and methamphetamine. Okay, so intoxication features includes euphoria, increased energy, mania, like something kind of mania. There's decreased appetite. There are dilated pupils. There is tachycardia. There is hypertension. There is chest pain, and there is paranoia. So features of stimulant withdrawal includes depression, fatigue, and hypersomnia. So, like depression, fatigue, increased sleep, or hypersomnia, there is increased appetite, there is anhedonia, there is loss of interest, and there is suicidal thoughts or thoughts of self-harm. The key point is in identifying stimulant withdrawal is that uh, after identifying stimulant withdrawal is that we need to understand that it's not life-threatening, but there is a very high risk of suicide. But there is a very high risk of self-infliction or self-harm in patients who are under withdrawal features of stimulants. There's a high risk of suicide. Uh, LSD, when we try to discuss about hallucinogens, LSD and PCP cause hallucinations. So LSD causes visual hallucinations most importantly. It causes time distortion in a patient. It causes panic attacks and also causes flashbacks about past. So PCP features includes vertical nystagmus, violence like aggression, psychosis, and analgesia. So whenever you come across violent patient and vertical nystagmus, you need to understand that he might be under influence of PCP. All right. So now let's discuss about Wernicke's encephalopathy, uh, confusion, ataxia, and eye movement problems or ophthalmoplegias. Uh, they together, all of these three together forms a triad of Wernicke's encephalopathy. Let's repeat it again. So the triad that is seen in Wernicke's encephalopathy is confusion, ataxia, and ophthalmoplegia. Confusion, ataxia, and ophthalmoplegia. Confusion, ataxia, and ophthalmoplegia. This is a classic triad of Wernicke's encephalopathy, and this is caused due to thiamine or vitamin B deficiency in alcoholics. So so this Wernicke's encephalopathy, because it causes ataxia and confusion, it's it causes many other psychological symptoms uh, and neurological features. So it must be treated as a medical emergency, and glucose should be given. But before glucose is given, we need to ensure that thiamine replacement is also done to those alcoholic patients. Triad is confusion, ataxia, and ophthalmoplegia. Korsakoff syndrome, there's chronic memory loss. There is chronic memory loss, and there is confabulation where the patient tries to make up stories. So this Korsakoff syndrome is a chronic complication of untreated Wernicke. Wernicke is a chronic complication of thiamine deficiency in alcoholics, and Korsakoff syndrome is a chronic complication of untreated Wernicke. We need to understand this. The key features of Korsakoff syndrome includes severe memory loss, confabulation, where the patient just makes up stories. The USMLE rule in identifying this Korsakoff and Wernicke syndrome is that Wernicke is an acute condition, whereas Korsakoff is a chronic condition. So now let's review substance abuse. Features. So depressants just slow down the patient, stimulants speed up the patient, and hallucinogens distort the reality. Okay, depressants slow down the patient, stimulants speed up the patient, and hallucinogens distort the reality of a person. So depressants includes alcohol, benzodiazepines, and barbiturates. The features includes slurred speech, ataxia, CNS depression, and poor coordination. The features examples of stimulants includes cocaine, amphetamines, and methamphetamine. So the features includes dilated pupils, agitation, tachycardia, hypertension, chest pain, and suicidal thoughts. Hallucinogens includes LSD and PCP. There's perceptual distortion. There is hallucinations seen. There are hallucinations seen, and there's disorganized behavior. So now let's discuss and try to differentiate intoxication and withdrawal. Withdrawal of depressants is dangerous, whereas uh, withdrawal of stimulants is depressive. So depressant intoxication uh, just causes slow, sedated, and slurred speech. Just slows down the person. It sedates the person and causes slurred speech in a person. What's that? Depressant intoxication. So in depressant withdrawal, there is presence of tremors, anxiety, seizures, and delirium. Whereas in intoxication with stimulants, there is presence of characteristics like agitation, chest pain, and paranoia. Lastly, when we try to discuss about withdrawal of stimulants, it causes depression, fatigue, and hypersomnia. So the rule is that depression withdrawal kills. It is extremely dangerous and fatal and life-threatening, whereas stimulant withdrawal is depressive. It might not be life-threatening and fatal, but it causes suicidal thoughts in the patients. So, as bad as intoxication is withdrawal too. So, we need to understand this key rule. Whenever we come across a confused alcoholic, whenever we come across a confused chronic alcoholic patient, we need to observe for features of ataxia, we need to observe for features of vertigo and confusion. So this is a triad that we have discussed in Wernicke's encephalopathy. So we need to diagnose it as Wernicke's encephalopathy. The management order is first thiamine, vitamin B1 replacement therapy, and then we have to give glucose. We should never give glucose first. We just need to remember this. This is a very key, important thing that we have to note down. Uh, Before glucose is started, we need to start the patient with thiamine replacement therapy because untreated Wernicke's may progress to Korsakoff syndrome. So the key differentiating features between Wernicke and Korsakoff is that Wernicke's is acute, whereas Korsakoff is chronic. There's confusion, ataxia, and ophthalmoplegia and Wernicke's encephalopathy. It is reversible if treated early, whereas Korsakoff syndrome is chronic. There's severe memory loss. There is confabulation, just makes up stories. This is often irreversible. So we shouldn't wait till this Wernicke's goes to Korsakoff because it turns to be irreversible, and we need to start giving thiamine and glucose to just reverse it because there's still a chance if we treat the patient early. So now let's discuss about patterns of substance abuse. So whenever we come across chest pain, dilated pupils, and agitation, the stimulant that should come into our mind is cocaine. Whenever we come across slurred speech and ataxia, we need to think about alcohol intoxication. So when a question mentions tremors and seizures after stopping drug, we need to think about withdrawal. Withdrawal. This could be a withdrawal symptom. Whenever we come across confusion and eye signs in an alcoholic, confusion, ataxia, and eye movement disturbances in an alcoholic, this is a classic triad of Wernicke's encephalopathy. Whenever there is memory loss and confabulation, so we have to think about Korsakoff syndrome. So when we try to discuss about eating disorders, so we need to discuss that anorexia causes low weight, whereas bulimia causes purging. And binge eating, there is no purging. So anorexia causes low weight, bulimia causes purging or compensatory behavior, and binge eating, there's no purging. So anorexia, there's very low BMI, there's fear of weight gain, there is amenorrhea, which is the most common feature in women suffering with anorexia nervosa, and there's bradycardia and hypotension. In bulimia nervosa, there's normal weight where the patient just binge eats food, and there's purging, and there's a presence of compensatory behaviors where they just try to vomit and also use a lot of laxatives. There might be presence of features like dental erosion. There may be presence of features like erosion of the calluses of the knuckles of the hands because they just try to put their hands in their mouth and just to induce a gag reflex to just vomit the food that they've eaten. So binge eating disorder, there are binges, but there's no purging, there's no compensatory behavior. They just eat a lot of food. So now, when we try to discuss about child psychiatry patterns, uh, we need to discuss these five conditions. So ADHD, there's inattention and hyperactivity in greater than two settings. In more than one setting, if there's inattention and hyperactivity, we can think about ADHD. Whenever there's poor eye contact, whenever there's language delay, and whenever there's repetition, we can think about autism. So conduct disorder should come into our mind as soon as we see something like aggression, theft, and rule-breaking behavior in a patient, probably less than 15 years old. So we need to think about conduct disorder. If these features are seen in a patient with greater than 18 years of age, we need to think about antisocial personality disorder. So Tourette syndrome is characterized by both motor and vocal tics for greater than 1 year, and enuresis is nothing but bedwetting after age of 5. So, uh, just we'll try to just take a quick recap of pregnancy psychiatry. So, postpartum blues last for days, and it's often mild, whereas postpartum depression lasts for greater than 2 weeks. Postpartum psychosis is an emergency. The rules that we have to consider is that we need to avoid valproate. We need to avoid valproate and carbamazepine because they are highly teratogenic and they may cause neural tube defects, open neural tube defects in the fetus. Lithium can cause Epstein's anomalies. So lithium is a mood stabilizer. Valproate is also a mood stabilizer. So whenever we prescribe these drugs, we need to understand that these shouldn't be given because they increase the risk of fetal anomalies, but ECT is safe in pregnancy. So when we try to let's try to quickly differentiate between grief and depression. So uh, normal grief, there's sadness after loss, where the patient just cries. The symptoms gradually improve, but the self-esteem is preserved. The symptoms gradually improve. So this is the key thing to remember. There's preservation of self-esteem, whereas in major depression, there is hopelessness, there is guilt, there are suicidal thoughts, thoughts of self-harm. There is no improvement. and there's always or lost self-esteem. So let's differentiate between dissociative and psychotic disorders now. So dissociative disorders, there's a presence of insight, whereas psychosis, there is absence of insight. So in dissociative disorders, there is memory or identity disturbance, which is triggered by trauma. Insight is usually present. There are no hallucinations or delusions, whereas in psychotic disorders, there are delusions and hallucinations seen along with a poor or no or absent insight. So, this psychotic disorder is usually a thought disorder. So, uh, now let's discuss about a master diagnostic framework for psychiatry. So whenever we come across a psychiatric question in step one or NEET or INCT, whatever it might be, we always need to analyze. We always need to question ourselves. What's the timeline? Whether it's an acute or a chronic condition, what's the trigger? If the trigger is acute stress, or chronic stress, or if there's any or traumatic incident that might have acted as a trigger for the patient, or if the trigger is a substance or drug that is being abused, we need to look at if the insight is present or not, if he's conscious of what he's doing, and whether he believes it's right or wrong, if there's functional impairment or functional disability, if there's any drug use, if there are any medical causes, uh, and if there's any personality pattern that is seen in the patient. We need to look up at these basic things whenever we come across a psychiatric question. Timeline is a key. Timeline is the most important thing halves out that just halves out most of our provisional diagnosis. So, looking at timeline is the most important feature. So, after that, we need to think about trigger, whether inside is present or not, if there's any functional impairment, if there's any drug use, if there's a medical cause that may have caused it, if it's a somatic pattern kind of disorder, or it's just psychological one, we need to identify that. So, these first three things are the most important: timeline, trigger, and insight. So these three are the most important that can help us just arrive at 50% of a diagnosis. So now coming to rapid recap, we'll just go across whatever we've discussed. So conditioning is learning by association or consequence. Transference is patient's emotions are transferred to doctor, whereas countertransference, where doctor's emotions are shown upon to a patient. So OCD, there's presence of insight. Personality disorders are always lifelong. They're chronic. This personality disorders are kind of lifelong conditions. ECT is safe, fast, and effective. So ECT is safe in almost all the conditions where we just give anesthesia and induce seizure in patients. So it's called as an electroconvulsive therapy. So alcohol withdrawal is always a dangerous feature. Whenever there's withdrawal features of a depressant, it is an extremely life-threatening emergency. Whenever there's withdrawal features of a stimulant, it's not immediately life-threatening, but it causes a lot of suicidal thoughts in that patient. Wernicke's encephalopathy, we need to give thiamine first and then glucose. And if we don't treat the patients early, this Wernicke's encephalopathy can progress to Korsakoff syndrome. The final message to everybody who have been watching my videos is that you need to use these videos to understand concepts. You need to use these videos to understand concepts. Then you have to read standard textbooks for your particular exams and then solve MCQs. Then we need to revise patterns. So this is how you score high without getting burned out. So this series, USMLE with Varun, is uh, started with a motto to just end the burnout and empower active learning. So I've come across situations where I was just fed up with a long lecture series where I don't get time to just sit down and read my book, sit down with just an active mind, see at my book and read it down, just wasting time, just passively watching a lot of hours of lecture series without any use at the end of the day. So I've created this series to make concise videos so that you can get time to sit down and read books and also solve questions. So I would like to request everyone to please. So I would like to request everyone to please subscribe and keep supporting. And voluntary support is always appreciated. That's not uh, really needed. That's a really optional one. But do subscribe and keep watching. There's the next series is going to be coming up in the next 1 week or 10 days. So where I'll be discussing system uh, in a proper systematic fashion. All right. Thank you. See you again. Bye.